I'll be presenting a case of Ivus and FFR guided Lmca bifurcation PCI using decay crush technique. So my patient is a 67-year-old male patient. He has a history of unstable angina in the past few months. ECG was normal, cardiac markers were mildly elevated, and the echo was normal. This is the angiogram. So you can see that there is some left main disease, some ostial LAD, some ostial circumflex disease. There is disease in the mid part of the circumflex. The LAD essentially is normal. The rest of the LAD is normal. It's a codominant circulation. And you can appreciate the calcium in the left main and the LAD in this view. The RCA was, it's a codominant circulation. There's not much disease in the RCA. So first of all, we needed to evaluate the significance of this lesion. We performed an FFR, and it showed positive FFR for both the LAD and the circumflex, significantly positive. We decided to give the patient the option of a CABG. He refused. So we decided to do a bifurcation PCI using the decay crush technique with imaging guidance. So this is the Ivus run from the LAD. We could directly pass the Ivus catheter. I'll just bring it close to the bifurcation. So here you can see that there's a calcified nodule which is protruding into the LAD, but here the lumen looks quite preserved. But as we come close to the bifurcation, so you can see that the distal left main and the ostial LAD is significantly diseased. The lumen may be close to around 2 millimeters. We then had to dilate the ostium of the circumflex to allow the Ivus passage. Again, we could see a calcified the nodule throughout and very severe stenosis at the ostium of the circumflex. Just move this close to the. So it's very calcified, and so it's basically a Medina 111 bifurcation disease with calcium. Now the lumen diameter at the minimum lumen diameter was around 2 millimeters. We decided to go in with a shockwave balloon which was a 3.5 into 12 millimeter. We delivered 30 pulses to the circumflex and then the rest of the pulses to the LAD. We could see a good expansion. So this is the I'll just show you the images. So this is the LAD pre-ostium. This is the distal left main. This is the calcified nodule which is protruding. This is the osteoproximal circumflex. These are the reference diameters of the circumflex, LAD, and the left main. And this is the shockwave balloon. So we can see that the expansion is quite good. And then we used a non-compliant balloon for the proximal and mid circumflex, a 3 millimeter balloon. We already have this 3.5 millimeter balloon parked in the LAD because we wanted to do a decay crush. This is a 3 into 34 millimeter stent with minimal protrusion in the left main. We deployed the stent, pulled the stent balloon back, went at high pressures, removed the wire in the stent balloon, crushed it with a 3.5 millimeter and then subsequently a 4 millimeter balloon to ensure an adequate crush. And then made efforts to cross through the proximal strut, opened the struts up with a 2.5 millimeter balloon, post-dilated the circumflex stent, did kissing the first kiss with a 3.5 millimeter balloon in the LAD and the circumflex, removed the circumflex wire, deployed a stent 3.5 into 38 from the ostium of the left main, flared the ostium of the left main with this stent balloon, did proximal optimization with a 4.5 into 8 millimeter balloon, recrossed into the circumflex again, opened the struts, then post-dilated the LAD with a 3.5 millimeter. And this is again a kissing with two 3.5 millimeter non-compliant balloon and followed by the final pod. So again, this is the Ivus run that we took from the LAD. Following this, all the steps of the decay crush. I'll just allow this run to be played. So the distal part of the stent looks okay, the areas were okay, it looks expanded, well opposed. But as you come close to the ostium, we can see there's mild under expansion, not very great, we could have left it. The area was around 7.5 millimeters. So, and this is the run from the circumflex. The area of the ostial circumflex was around, again, 7.3, 7.4 millimeters. Acceptable areas, but we felt that the LAD ostium was still mildly underexpanded. So what we did was we did a second, again a kissing with a 4 millimeter balloon in the LAD and a 3.5 millimeter in the circumflex, and then did a final pot again. We also realized that when we went back to the circumflex pre-stent, we had some disease in the circumflex, which we had actually ignored, and so we decided to put another stent there. Pre-dilated with a 2.75 and then put a 3 into 18 millimeter stent, and again did a pot and then did a final run. So this is the final angiographic image, and did again the final run from the LED. In want of time, I'll show you the images. So this is the left main at the end of the procedure, 15.6 millimeters. This is the polygon of confluence, where we could see that there was very little metal in front of the circumflex. It was a typical 8 appearance that we can see on the IVUS. This was the ostium of the circumflex, and this is the LAD ostium post the first kiss, and this is the LAD ostium post the second kiss. So there's a significant improvement from a 7.5 to an area of 10.8. So the take-home message is that physiology is a must-have tool in ambiguous lesions. Calcified left main bifurcation requires meticulous planning. Imaging is essential, and selection of proper plaque modification tools and decay crush remains the best bifurcation strategy for a left main bifurcation PCI. Thank you.